All right, I think that one more minute and we could start. Well, I think that everybody that is going to come has joined us. Welcome. Some of you have already started hearing a little bit of the preparations. This is new for me, and I think is a new way of doing symposiums, which is a pretty interesting feature. This is the Cancer Disparities Symposium breakthrough meeting, and we have 4 very interesting posters, very diverse in their methodology, in their topics. So I think that that will give us a pretty good vision of cancer prevention and control research. Let me introduce myself. I'm Celia Kaplan. I am faculty in the Division of General Maternal Medicine, and I'm also a member of the Cancer Center. And my research has always been on cancer prevention and control, so I was very excited to be able to moderate this session. I also would like to introduce Tiffany Cheng. Tiffany is going to handle all our technical aspects. So, and she's going to give you some instructions how to zoom in on the posters. This is something that please pay attention. So, because otherwise it could be a little bit small for you. Tiffany is a member of the Office of Diversity and Outreach at UCSF. And they have done a marvelous work in putting together this symposium, first time online. All right, so we already talked to the presenters and we gave them some few instructions. So for the rest of the audience, we thought that it would be great if you guys can be all online. We can see you on video, so that can keep us all present and active, and we could see your faces. Thank you very much. And also, I think one of the most important parts of this is the Q&A. So use the chat, not to send us kind of little messages, just to send us questions, so it's easy for us to look at them. We also, the presenters will put their email when they present. So if you have additional questions, you could contact them in the future. This is a good way of interact with our colleagues, and we usually do it in person. We don't have that ability this time. All right, Tiffany, would you like to show them how to Zoom before we start, or is this a good time? Okay. So
in this chat, so but feel free to direct message me if you have any questions.
All right, good. So I will first, I would like to start with our first presenter, Dr. Cheng. Dr. Cheng is from the research office of Kaiser in Oakland. But if you look at their authors, what is very interesting, that this is a collaboration that goes all over the country. And I think these are things that we would like to see in our research. So welcome, Dr. Cheng, and you can tell us your title and start your presentation.
Yeah, thank you. So could you hear me?
Perfectly well.
Okay. Thank you for your time and interest for joining today's talk. I'm Cheng, a postdoc at Kaiser Permanente Department of Research. Today, I will talk about neighborhood and individual socioeconomic disadvantage and survival among patients with non-metastatic colon cancers. So as you know, socioeconomic status, SES, is a very complex concept describing the state of income, wealth, education, occupation, and living conditions for both individual and neighborhood level. Disadvantaged individual and neighborhood SES result in worse survival outcomes. However, there are many important knowledge gaps. The first one are effects of individual and neighborhood SES independent or synergistic to result in worse cancer survival. If independent, we need to improve individual and neighborhood SES, at the same time to improve cancer survival. If synergistic, if we improve one SES exposure, it will indirectly attenuate the effect of another SES exposure. So second, most studies focus on overall mortality. However, more studies in cancer-specific mortality are needed. Third, we really need a comprehensive measure of neighborhood SES because most studies used a single domain neighborhood SES measure or overly simplistic composite measures of neighborhood SES. So in this Serum Medicare study, we use area deprivation index, ADI, to assess neighborhood SES. It consists of 17 measures of education, employment, housing quality, and poverty. To assess individual SES, we used Medicare, Medicaid, dual eligibility, DE, a unique indicator for patient-level low income. For example, in California, your annual income before taxes must be lower than $17,000. So for the Serum Medicare database, it is a large national cancer database linking Serum to Medicare. It covers elderly cancer patients over 65 years old, which accounts for 63% of the cancer population. And in this study, we focus on breast, prostate, lung, and colorectal cancer because they are the top 4 common cancers. We use the ADI 2018, the most latest version at the time of our study to assess neighborhood SES. It ranges from 1 to 100 points. Higher ADI points suggest higher neighborhood socioeconomic disadvantage, and we categorize ADI into quintiles. For dual eligibility DE, which was determined by each state, it is a binary exposure, yes versus no. And we focus on overall and cancer-specific survival as outcomes. We applied Cox proportional hazard regression after adjusting for different covariates. And to assess individual versus synergistic effects, we include the interaction term ADI times DE in our models. So here comes our results highlighted in red. Compared to ADI Q1, the most developed neighborhoods, patients living in ADI Q5, the most deprived neighborhoods, have higher risk of mortality regardless of their cancer types. And for DE, if patients were dual eligible, an indicator for low income, they also had higher risk of mortality regardless of their cancer types. Similar findings were observed for cancer-specific mortality. So let's move to the right for the interaction. If the interaction were significant, it suggests synergistic effects, otherwise independent effects. So only in overall mortality for colorectal cancer, we found significant interactions. But if we look into the effect size, 1.08 versus 1.04, they are very similar. So they may be statistically meaningful, but not really clinically or public health meaningful. So conclude, neighborhood level and individual SES were independently associated with overall and cancer-specific mortality, and no interactions were detected. So to improve cancer outcomes and reduce health disparities, policies for ongoing investments in low-resource neighborhoods and low-income households are needed. And we really need to invest both in neighborhoods and individuals to improve cancer survival. And we could not ignore either one to achieve this goal. And thank you for listening and welcome your thoughts.
Thank you so much for your presentation. Let me see, if you can please type some questions, that would be great. I have 2 questions actually for you. Number one, in your analysis, what other factors did you enter into your multivariable analysis? So what other factors are also affecting mortality? And my second question is, all right, we want to do interventions. What are the interventions that you think more concretely would you suggest to improve mortality?
Yeah, that's a great question. So first, as bottom of the middle, we include the covariates we adjust for. So we adjust for age, sex, marital status, stage, and comorbidity, surgery, radiation, and chemotherapy. And somehow, I think the race and ethnicity we're also adjusting for, but I did not include in the slides. And also for breast cancer, we additionally adjust for the hormone receptor status. And for prostate cancer, we also adjust for the androgen deprivation therapy. So we did use very careful models to really get the most accurate adjust hazard ratios. And second question to answer that, how we should really achieve that, this is really a policy question, and it's not like a yes or no, or maybe there is not really easy answer. But given our findings, we really felt like, you know, people who argue like if we just improve the neighborhoods and then we can just solve most things, or maybe we just send money or improve their occupations and give job opportunities to the people in the personally maybe deprived socioeconomic status, we can improve that. But these two arguments are actually not aligned with our findings, because we found that we need to actually improve them both. So we do think our findings have some policy implications, but there is a really long way, because the health disparity is actually just a symptom of, you know, many structural inherited in our society, you know, the racism and also segregation and also disparity in the job opportunities and poverty, etc. So this is really a long way to go, and we definitely would like to collaborate with people with different expertise to solve this question.
And did you find, since I don't have any questions, I keep on going for a little bit, did you find race ethnicity to be significant independent predictor?
Yes, we found that. So okay. We found that, but this paper is really focusing on the neighborhood and individual. So we did not report that. I think there are many papers looking into how the race and ethnicity impacting cancer survival, which are very important. Yeah, and in the future we could also look into that.
Okay, good. Does anybody have any questions, the other presenters, or no? Okay. Don't be shy, guys. All right, so we're doing great. Thank you very much. It's very important work, and I think a lot to look into it. I'm always curious about rural versus urban. I think that eventually that would be a question for you also to deal with. Okay.
Thank you for your question.
Oh, okay. This is what Stephanie asked. How about regional effects?
Yeah, that's a great one. So I have done some work in the urban versus rural regions, but I look into the haptoma. So I think there may be maybe the next step we should really look into. But also, as you know, the rural regions are generally considered as maybe somewhat level neighborhood disadvantage. So I assume there should be a very high correlation between the deprived neighborhoods or regions with rural areas. That's a great suggestion. I think in the next step, we should really look into that for these 4 common cancers beyond my current work in the liver cancer, the haptoma. Yeah.
Thank you so much. And we move now to our second presenter, Brandon Horton, and he's also from the team from the research group from Kaiser Permanente, which is great. So he's going to be, he can tell us a little bit about the title.
Yeah. So thank you for having me, of course. And yeah, today I'll be presenting our results from our study on the race-specific trends in prostate cancer screening and presentation before and after the 2012 USPSTF statement. So the goal of this study was to assess the temporal changes in the race-specific rates of prostate-specific antigen screening, prostate biopsy, overall cancer detection, and metastatic cancer detection at presentation among our screen-eligible members at Kaiser Permanente, Northern California, and specifically as it relates to the 2012 United States Preventive Services Task Force, or USPSTF, prostate cancer screening statement. So the guidelines around the use of PSA-based screening have varied over time, but the guidelines set out by the USPSTF have been favored by primary care physicians. Now, in May of 2012, the USPSTF gave a D grade, or discouraging the use of this service, to PSA-based screening for prostate cancer. So we decided to take a look at this with a retrospective study looking from 2006 through 2017 of PSA screen eligible members. Now, eligible in our case is defined by the Kaiser Permanente National Guidelines, and that's Black men ages 45 to 69, and then all other men ages 50 to 69 with no history of prostate cancer. Nice thing about us is we're lucky to be able to have a complete denominator of person time for our rate calculations, as we fully capture healthcare coverage and utilization through our EHR. So we'll be able to present more true rates. So if you want to, feel free to zoom in towards our figures. I'm going to be talking about figures for the rest of this. So figure 1 in the top left is looking at PSA screening rate by race. So the USPSTF statement will fall in the middle of these graphs of that 2012-2013 period. And as you can see in that, we find a decline in PSA screening rate, roughly 22 to 25%, depending on the race, starting right around that statement period. Of note, across our study, our Asian population in red had the highest PSA screening rate. Then our Black population in dark blue and white population in green had similar lower rates. And the subgroup of younger Black men in light blue had the lowest screening rate. Now, figure 1 relates directly to figure 2, where we present the biopsy rate. And you can see at that same time period, there's a decrease in the rate of biopsy across all races, roughly 47 to 57%, depending on race. And of note here, you can see that Black men were actually consistently biopsied at a higher rate, whereas Asian and white men were biopsied at a similar lower rate. Now, this relates directly to the fact that Black men had a higher percentage of abnormal PSA results, or likely was related to that. And then, of course, our subgroup of younger Black men in light blue had the lowest screening rate, or biopsy rate, I should say. Now, figure 3 is where we get into our interesting bits of cancer detection rates. And here we also find that decrease present, again, in that 2012-2013 period, with an overall decline of roughly 34 to 48%. Now, of note here is that our Black population consistently had the highest cancer detection rate. And prior studies have found that Black men have both a higher incidence and mortality for prostate cancer and should be considered a high-risk group. And then our slightly less lower detection rate for white men, and then Asians, who actually had the highest screening rate, or PSA screening rate, had the lowest cancer detection rate. Now, here's where we get into the interesting meter portion of our study, is that when we look at our figure 4, this is our metastatic cancer detection rate. And we actually find that right around that time of the USPSTF statement, we find an increase in all races, or across all races, of metastatic prostate cancer. Now, this increase was 39 to 105%, depending on race. And similar to the cancer detection rate, Black men had the highest rate, followed by white and then Asian men. And looking at the slopes of the increase, we see that the Black men actually had the highest increase in metastatic cancer as well. Now, the first 3 figures combined may have reflected the intent of the USPSTF statement, which was a reduction or avoidance of testing and detecting indolent prostate cancer or slow-growing cancer that wouldn't have a significant impact on a patient's morbidity and mortality. But the bottom line here is that these guidelines had a direct impact on the rates of PSA screening and thereby the cancer detection rates. And these data suggest that clinical impact of future guidelines may be improved by more emphasis on our high-risk populations. And while a causal relationship cannot be proved with the observational study, a growing body of evidence has noted a similar temporal observations around this time period. So our hope is that policymakers can use our studies and other like it to create guidelines and better address those high-risk populations.
Well, thank you. Thank you. Very, very interesting. And let me see if you have any questions. Anybody? So let me understand this well. So you're basically seeing more people, that a higher proportion of people with metastatic disease versus lower stages where it's treatable. Is that correct?
So the idea that we're trying to get across here is that with the decrease in our PSA screening rate, we had the increase in the metastatic cancer rate. The actual rates you can see are significantly different. I mean, we're looking at 0.1 to 0.6 per thousand person years versus in the general cancer detection rate of 1 to 10 per thousand person years. So our main concern would be just that as we have the decline in the PSA screening, that increase, and then that even more significant increase in our Black population, which the use in the terms of high risk has been used in other guidelines and other studies, and we would generally say individuals that are at a higher risk of developing cancer, and then at a higher risk of developing high-grade cancer, but it's how I'd potentially define higher risk. That includes Black men and also individuals with family history.
So we have two questions, and I hope they're both pretty good questions. Do you think more advanced imaging techniques are driving, at least in part, higher rates of metastatic disease diagnosis? And the second question is a concern about that, any potential advocacy of race-specific guidelines. How you feel about that? And you can take it in the order you prefer.
Yeah, so in regards to the imaging-based diagnoses, I think I'm not entirely qualified to discuss, the rates or increases in metastatic cancer detection based on imaging results, but I would have to assume that the imaging would be done based on PSA screening to begin with, unless somebody came in with clinical characteristics indicative of metastatic cancer, the various bone metastasis issues and things of that nature. So I can't quite comment on the effect of imaging, other than to say that it's an excellent tool to be able to have available to people, but we'd like to promote the use of PSA screening as our baseline. The second portion, or the second question, that was they were asking.
Let me read it to you. The question is, I'm very much worried about any potential advocacy for race-specific guidelines.
Okay, and that's absolutely a fine worry to have, and an excellent question. When I suggest having race-specific guidelines, it's usually the intervention would be education. It's education to providers and to patients, saying that there is a higher risk, and we have shown that there is a higher risk for incidence of prostate cancer and a higher risk for metastatic prostate cancer. So when we discuss race-specific guidelines, we would basically want to encourage individuals to obtain screening at a rate that would at least result in reducing this disparity in metastatic cancer detection. If individuals are going to be at a higher risk for incident prostate cancer based on genetic or environmental backgrounds, and there's not much we can do about that, but if we can discover those cancers early and establish a grade earlier, we might be able to capture it before it becomes metastatic cancer.
Okay, thank you so much. It's a very interesting, and I think that there are more questions. If you could please put your write down your email, people can contact you. All right, we're going to move to the third presentation, and this is another group. That's the group from UC Davis, our sister institution, and it's led by Dr. Laura Fecherman. But the presenter for this is going to be Valentina Zavala. So Valentina, is Valentina?
Fabian?
No, Fabian. I'm sorry, Valentina. So it's Fabian Perez. Fabian, why don't you start?
Yes, thank you. There we go. So hi, everyone. I'm Fabian Perez. I am a member of the Fecherman Lab at UC Davis. And today I'm going to be discussing Tu Historia Cuenta online version, promotores experience and perspective on the virtual adaptation of a hereditary breast cancer, or HBC, education and risk identification program. So to start, breast cancer is the leading cause of cancer-related death among US Latinas. and US Latinos are more likely to be diagnosed with advanced stage disease. This can be attributed to longer times to follow up after an abnormal mammogram result, lack of insurance, and many other barriers. But Dr. Laura Feckerman partnered with the Latino Cancer Institute to develop a culturally appropriate and comprehensive promotores-led HBC education and risk stratification program for Spanish-speaking Latinas, with the aim of increasing mammography screening, genetic testing, and the understanding of the impact of family history on cancer. And we partnered with two Promotor de Salud organizations, Promoters for Better Health down in Los Angeles, and Visión y Compromiso, which are based out of Sacramento and San Francisco. So those were our three areas that we were focusing on. And originally, like many other studies, this was meant to be in person. And right when we finished our training, COVID-19 hit. So we completely transitioned to virtual. So this poster today is about the Promotores experience through the virtual platform. So a little bit more about our participants in Promotores. So we had a total of 14 Promotores de Salud, all of which were fluent in Spanish. They self-identified as Hispanic or Latina, and they were mostly first-generation immigrants. So we did a quick demographic survey on them. 64% of our Promotores self-reported as having an education level of high school or less, and 45% stated that they had a basic understanding of the English language or proficiency. And their mean age was around 46. As for our community members / participants, as of September 1st, we had 762, all of which, again, were Spanish-speaking or bilingual women who self-identified as Hispanic or Latina and were 21 years or older. And for them, 75% self-reported as having high school equivalent or less, and 37% self-reported as having a basic understanding of English or less, with a mean age of 43. So our promotores and our community members are very, very close and similar in terms of demographics. So we used two surveys to collect information from our community members. One was a simple demographic survey, and the second was a survey on family history, which we used to determine their risk status for hereditary breast cancer. So one of the things that was incredibly important to us was giving our promotores a voice. So they were given the opportunity to share their thoughts without the researcher's interpretation. And as a result, they are writing in the paper that we're hoping to publish soon. So they are co-authors on our paper, and the promotores are also co-authors on this poster and the other ones that we've been presenting. So we really focused on bidirectionality and continuous stakeholder engagement. So I had weekly communications with the promotor leads, and it was around quarterly meetings with all the promotores in the entire research team. So we did do informal conversations, and they gave us a few really interesting quotes. So one of them is, "I see myself as capable of teaching a topic like genetics. I am more confident as a person. I bettered my public speaking skills, and I believe that I can support any research project because of everything I have learned this year." Another promotor said, "To be a promotor de salud is to act as the bridge and connection between communities and researchers, resources, and doctors." And then in terms of the transition to a fully virtual program, one of our promotores said this was a positive. So I quote, "Some of the strengths of using the virtual platform is that we can do it during the times that the participants are available. They can take it from the comfort of their own home, and it makes it more convenient for them." And then another promotor stated a negative aspect of it, which was, "On the part of the participants, there's a lack of privacy in their homes, so I think they are not able to express their concerns or questions openly and comfortably," which I thought was incredibly interesting. So in conclusion, the Tu Historia Cuenta program provided unique opportunities for bidirectional collaboration. Our promotores expressed advantages and difficulties associated with the virtual program. Most importantly, they expressed feeling empowered and appreciated in their efforts within their communities. And they mentioned increase in self-esteem, increase in confidence, And many of them expressed their interest in joining other research studies. So they're really interested in working with more researchers on different topics. So lastly, I would like to give special thanks to Dr. Laura Fescherman, the PI, all the women that participated in the program, along with our promotores, and special thanks to the Governor's Office of Planning and Research, whose funding made all of this possible. Thank you.
Thank you, Fabian. We're going to take one question or two questions that from the audience. Okay, so this is a study, and how is it being implemented once the funding goes? One of the things that we all struggle is, are these organizations taking it on their own? Are they searching for funding? How is this working out?
No, so we got funding through the Governor's Office of Planning and Research, and we're funding the promotores efforts. So we're paying them, which they were super, happy about, especially during COVID. A lot of people lost their jobs. So through us, they were able to continue working and continue to get paid. So that was kind of another aspect of this, is we think it's really important to not just use promotores and have them volunteer their time, which is kind of the common practice, unfortunately, but to really reward them for their efforts, because they're a really big component in research, especially community engaged research.
Rightly so. And keep it short, the answer, so we can move forward. What do you believe is the strength of qualitative research in cancer health research?
I think it's really important, because I think cancer is not just about numbers. So I think it's very important to kind of have the incidence and the odds ratios and all of that. But I also think it's also about how to figure out, because at the end of the day, we're humans, right? So we have to figure out what their experiences are and how we can make it better through treatment, through survivorship, all aspects of the continuum of care in terms of cancer.
Thank you very much, Fabian. It was a great presentation, and I think that's the right thing, to move the research to the people is one of the biggest challenges we have. And our last presenter is Valentina Zavala, also from the lab from Dr. Laura Fescherman. And she's going to talk about the polygenic risk scores for breast cancer. And this is an interesting collaboration with an international collaboration. So we have had all the ranges of possibilities, and that's pretty good. Go ahead, Valentina.
Thank you. Hello, everyone. Today I'm going to show you some results on the assessment of a previously reported polygenic risk score for breast cancer in Peruvian women. As a background, I would just like to mention that around 2% of the genetic predisposition for breast cancer is explained by mutations in high and moderate penetrance genes, while the remaining genetic predisposition is explained by common genetic variants of a relatively small effect. Most of these variants that are associated with breast cancer risk have been identified in big cohorts that are composed mainly by European and Asian individuals. And they have been able to combine all these variants into a polygenic risk score to predict breast cancer risk. So the aim of our study here was to test the association of this PRS, or polygenic risk score, composed of 313 SNPs, and in women of a high indigenous American ancestry from Peru. For this purpose, we included women that have been diagnosed with breast cancer that have been recruited by the National Institute in Lima, Peru. And we also had access to genotype data from women that don't have a diagnosis of breast cancer and that are part of pregnancy outcome studies that are also from Lima, Peru. And this we included as convenience controls. The polygenic risk score is a value that you estimate per individual, where you sum the number of risk alleles for each of these variants that are associated with breast cancer risk in this case, and where each variant is also multiplied by the magnitude of the effect. In this case, we use the beta coefficients from the association study from the European cohort. So when you put all the PRS together, we will get a continuous distribution in the population where most of the individuals will have little or no risk for breast cancer, while we will have a few individuals that are protected or are either in higher risk for breast cancer due to their genetic background. Well, the first thing we did was to compare the odds ratios in our Peruvian study with those odds ratios from the European and Chinese studies in figure 1. And we saw a very good correlation. However, there are some SNPs, here we highlighted them in red, blue, and yellow, that were significant in our Peruvian study, but show an opposite effect in the European and Chinese cohorts. In figure 2, we can see the distribution of PRS in cases and controls, and we can see that cases as expected tends towards a higher PRS. In table 1, we tested the association between PRS and breast cancer risk in the Peruvian women. And the area under the curve was 0.58, which was slightly lower than the ones reported in the European and Asian cohorts, which were 0.63 and 0.61 respectively. The logistic regression model shows us that per unit increase in PRS, the odds for breast cancer increased in 1.7. After, when we stratified analysis by quartiles of indigenous American ancestry, we saw that there was no difference in the odds ratios between these groups. Finally, in table 2, what we did was to stratify the PRS into deciles, and we can confirm here that among the individuals that have a lower PRS values, these individuals were protected against breast cancer risk, while higher values of PRS are associated with increased risk for breast cancer. In conclusion, we confirmed the association between this previously published PRS and breast cancer in a cohort of highly indigenous American women from Peru. The magnitude of the association of the area under the curve wasn't different between quartiles of indigenous American ancestry. And finally, and most importantly, the similarity in the area under the curve estimates by ancestry in a study where the highest quartile here in table 1, we can see it includes women with more than 92% of indigenous American ancestry, suggests that the PRS that was developed in Europeans can also be used in Latin American populations with high indigenous American ancestry. Thank you.
Thank you very much. Any questions from the audience? I will go first, and this is not my area of expertise, so bear with me, Valentina. How the polygenic score compares to the risk, because we cannot do this on people, all the time. Mm-hmm. How this compares with the standard risk assessments, like, I don't know, the one from the Breast Cancer Consortium. How much does this add to the risk, to assess the risk of a woman of Peruvian descent or any descent, since there are no differences here with the Europeans? You follow my question?
I think so. Let me know if I'm not right. No, I'm not going the right direction. Yeah, I agree that PRS for individual assessments so far it seems to be something very difficult to accomplish, especially in Latin American countries where we barely can make accurate. Not that we cannot make it, but the funds for proper diagnosis and follow-up for breast cancer patients is not guaranteed for everyone. But I think that having this information at the population level is knowledge that is important for public policy decisions, and of course in the future this is going to be knowledge that is going to help us to prevent and control and manage breast cancer in Latin America for sure.
Okay, there's a question from Dr. Cheng, could you explain your studies population? I think you mentioned two populations, PROMISE and PGBC. Are there Peruvian American women or containing European Chinese women in their samples?
Yeah, both cohorts are women from Peru. Peruvian women have been recruited by the INEN, which is the National Cancer Institute of Peru. We have a collaboration with them. And we are also established a collaboration with Dr. Helaya from Harvard, who is leading the PROMISE study. This study aims to evaluate pregnancy outcomes in young women from Peru. So they tend to be a little, of course, younger than our cases. We're working on trying to be able to make these two groups more comparable. But yeah, both of them are highly indigenous Americans. In average, cases have a 76% of indigenous American ancestry, while controls have a higher average indigenous American ancestry of 81, which has been already reported before because indigenous American ancestry is associated with lower risk for breast cancer.
Thank you very much. If we don't have any other questions, I think that I would like to thank everybody that participated, the audience, the presenters. And I invite you to continue, I think that with the symposium, and I give you 2 more minutes of a break because they are not giving you too much of a break with 5 minutes. So if somebody has a question, a last question, we can do it right now. If not, we'll.
I put the link back to this main symposium in the chat, so feel free to use that to get back into it. It will restart again shortly.
Wonderful. Okay, so I let you go. Thank you so much, Tiffany. Thank you for your help and all the presenters. It's really very exciting work and that you all are doing, very different, but between all the pieces, we probably can improve cancer prevention and control in the future. Thank you so much.